Good morning, y'all. Good noon, good afternoon. Welcome to Friday Virtual Morning Report. I want you all to take a moment to stare at Prof. Rez's left chest. And that's what we're doing today. DXRLR. Prof. Rez is the sole owner of this merch. He has yet to even share it with me, though one day I look forward to possessing a shirt of that beauty. But yeah, today's RLR, and if you're new to CP Solver, it stands for Rabih Loves Reza and nothing else. Uh, no other version. Prof. Rez, let me hand the mic to you to say a quick hello, and then we can welcome and thank everybody who's making this happen.
Man, I was just gonna say medicine is so exciting. So I'm working right now, and like yesterday we had an interesting case, and like all I was looking forward to today was seeing the progress of that case and the outcome of that case. I
Yeah,
can't I can't share it because it might be, you
I
know,
see.
yeah, it might be behind the paywall.
Mm.
So, but for the YouTube people listening, I don't care. I said it and I say it proudly.
Hey, Prof. Rez, what paywall are you referring to for those who don't know?
Robbie, you don't want them to hate you too, do you?
Prof. Rez, remember my newfound attitude to life? I'm just going to talk calmly and slowly and just chill. So, no, I don't want them to hate me,
This
but I
is
don't mind if they do. No worries.
rlrcpsolvers.com, where we're real about medicine and we have fun. And it won't make you better at any exams, but it'll make you better at taking care of patients and enjoying the field of medicine.
Oh, wow. Okay.
Dude, we captured that. I'm going to say that. That should be our
Yeah.
commercial.
Yeah. 100%. Sign me up. Where do I sign, Prof. Rez? I'm down. Um, Amazing. Well, thank you for that plug. In this new calm, slow version of me, my transitions are a little bit less smooth, but I'll get there eventually. Um, so today we have case 100,000 from our beloved Anmol. But before we hand the mic to her, let's thank the two people who are anchoring this session. The first is Simi. I'll hand the mic to you to update folks on what's happening in your life, Simi.
Hello, everyone. Very excited for the session. And I just want to say that I love your shirt, Prof. Rez. Please gift one to Robbie as well. It's very cool.
Lyra, mic to you.
Yeah, hi everyone. My name is Lyra. Yeah, enjoying free time listening to CPS podcast. So make sure to listen to the new episodes if you haven't.
We're all in plugging commercial mode today, huh? Amazing. Anmol, mic to you. What's new?
Hello, everyone. Good morning, good afternoon, and good evening. My name is Anmol Preet, and I'm here for another case presentation. After that, I will go for my evening shift of the rotation.
Oh,
And this is one of the cases I saw in the later part of the job in India when I was.
I see.
So I had written that down, and I'm very excited for today's discussion and to see how Dr. Rabi and Dr. Reza analyze all the things and what are their perspectives. It will be very interesting for me for my whole learning about the case.
Anmol, when did you start to do evening shifts for your rotation?
Not the evening one, but you have the lunch break. After that, then from the 1:30 to 5 p.m.
I see. Understood.
afternoon shift.
Understood. I know. I understand. Understood. Yeah. After people's afternoon is also my evening. Don't worry. I know exactly what you mean. Okay. All right. We'll hand you the mic, and then we'll hear from Prof. Rez for the first hour.
So to begin with the case, I have divided it into around 6 to 7 aliquots, and we will see the division of aliquots as we discuss. So I'll start with the case. The chief complaint with which the patient is coming up to the hospital is fever and generalized pain in the legs for 4 days. A little bit about the history of present illness is that she is a 58-year-old female who presented to the emergency department with the complaints of having fever 4 days back, which was accompanied by generalized weakness and reduced oral intake. She also reported having generalized pain in her legs, which is not present at the baseline. Her oxygen saturation reportedly fell down to 60% in an outside facility, and she was dyspneic. Her blood pressure also was on the lower side in their documentation. and she was tachycardic to a heart rate of around 170. So she was stabilized there and then referred to our hospital. Some of the documented treatments they gave was probably a diuretic or an antiarrhythmic to actually stabilize the heart rate. But till now, we just know this, and the patient is referred to our emergency. I'll stop here.
Good morning, Amol. This is a great start. Nice to see you, my friend. Maybe what I can do is just tackle the chief concern and leave the HPI for Rabih to dissect. And I think when you're seeing fever, your mind translates that to inflammation. And then the question becomes, what is causing the inflammation and where is it coming from? And we often prioritize infection, as we all should, at time point 0. And once infection is thoroughly evaluated, and the days go on and the fever persists, then you can sort of start asking, is this an atypical infection, a cancer, an autoimmune process? But just from the chief concern, when you say fever, not looking at the HPI and leg pain, I'm just really worried that there's something going on within the legs that are causing the inflammation that's leading to the fever. And if you ask the question, what could go on in the legs that can lead to inflammation and fever? Really, and if we stay true to starting with infection, it could be cellulitis, but cellulitis would be very odd to be bilateral like this. It could be something way more sinister, like necrotizing fasciitis, which is truly a medical emergency. Or it could be an abscess or a bone infection. I purposely did that because I wanted to just reinforce the process of solving a case with fever, which is inflammation, likely infection, go where the symptoms are. If there are no localizing symptoms, then it becomes more difficult. But I know we have a richer HPI that we can overlay on that and make even more progress in refining the problem we're trying to solve.
Yeah, 100%, Prof. What an awesome alley-oop. And I have to say, I was really surprised, I bet you were too, that a story that begins with a 58-year-old woman who's having fever, generalized pain, especially in her legs, then evolves to such serious cardiopulmonary compromise. I was anchoring in the reality that when most people feel achy from head to toe, they often have a milder illness presentation from a viral disease process. So to be honest, I was quite surprised that this person has both cardiac and pulmonary collapse. More specifically, she has alleged to have hypoxemic respiratory failure and alleged to have the dreaded combination of tachycardia and hypotension. And so because we're very early on in this case, it's hard to apply more specific labels, but I think you can have a very powerful operating assumption when the two dreaded things, hypoxemia and hypotension, are happening simultaneously. And the two common explanations for the simultaneous occurrence of hypoxemia and hypotension is that a patient has a pulmonary infection with sepsis physiology, with the infection causing the hypoxemia and the sepsis physiology causing the hypotension. That's bad enough, but what's even worse is when there is cardiac disease so bad that it causes backup of flow into the lungs, causing cardiogenic pulmonary edema, and impaired forward flow causing hypoxemia. So I would have those two things as my anchoring principles. Is this a pulmonary infection with sepsis, or is this cardiogenic edema? Pulmonary infection with sepsis is more common, but cardiogenic pulmonary edema with hypotension is more morbid. And so I will be trying to filter the rest of this case through those two lenses, and would probably acknowledge that a fever suggests the more former hypothesis of infection in the lung, but a fever can also originate in the heart. So we'll see how the case evolves, but I think we really have to sit up and pay attention because of how sick the patient is.
Great start to the discussion. I love it, whatever you said. So I will just expand on the HPI. So over these 4 days, she visited two outside facilities over these 4 days. So initial blood work performed outside 4 days back revealed severe anemia, for which she received an intravenous iron preparation. Then the patient returned back to her home, after which she developed persistent nausea and multiple episodes of vomiting. She had been feeling very uneasy for these 4 days. Then she checked her blood glucose at home 1 day prior to this presentation, which was reportedly low after all these vomiting. Then the repeat evaluation, she went to another facility. The repeat evaluation at that center revealed evidence of kidney injury on laboratory tests. And then basically now she had come to the hospital for the further admission, for the further management. There was no pain in the abdomen, no loose stools, no burning micturition, or no chest pain. And something about the past medical history, she was diagnosed or documented as a case of rheumatoid arthritis. Somewhere in the records it was mentioned, but we don't know how it was diagnosed. And there is no history of hypertension or type 2 diabetes mellitus. Regarding the surgical history, she has a history of knee replacement 4 years back. And patient is currently not on any medications. She's not taking any medications. And the family history, there is no known family history and there are no known allergies. Regarding the social history, there is no history of any recent travels, and the patient lives in a rural area in India. She does not drink alcohol and is a non-smoker, and there is no known animal exposure as well. I'll stop here. Maybe a brief pause.
Yeah, Anmol, I think that what you're illustrating is a very common reality for hospitals that accept patients who are transferred, which is that there is a backlog, a cumulative pile of information to sort through. And as is true in most instances, that information can be chaotic and hard to arrange in a linear flow. And so naturally, what I would do now is actually recognize that I have some access into this patient's past, but I would probably begin to construct my story of this patient by first asking her what's bothering her now and examining her. I think if you replicate the idea of what it's like to receive such a patient and to try to put together this story and come up with hypothesis, I think the majority of the time, the moment you meet the patient, talk with her and examine her, you'll realize that you probably wasted your time. And so my advice is the present is always more informative than the past. Ignore everything now. First, talk to her, see what's bothering her now. Examine her and see what clues the disease is leaving now. And then go back, close your eyes, and try to use the past to your advantage to help you plot your next steps. So the authentic answer here is, Anmol, I'm going to review everything you said in excruciating detail, but only after we talk to her and examine her. I'm really curious, Prof. Rez, how you're handling this whopping amount of information.
I think you said that so brilliantly, because I think the mistake that we often make, Robbie, is we focus on some detail in the past, like a travel, a historical diagnosis, and we get sidetracked and pigeonholed or narrowed in our approach with putting that on a pedestal. The past travel, the past RA, that would be a huge mistake. All the past does is it broadens, it doesn't narrow. So it might trigger two frames, but the more important frame is what's happening before us. So right now, like, I'm just thinking, wow, if we have hypotension, hypoxemia, concern for sepsis, in someone who may have an autoimmune disorder, maybe on some kind of immunosuppressive therapy, I'm just rushing to the exam and to the labs to help really, I think, focus more on management and stabilization. And then later on, step back and put on my clinical problem solver hat. Both are happening simultaneously. But for me, like, this whole story is just really worrisome for something serious happening rather rapidly.
Do you have a clinical problem solver's hat?
No, but I have a shirt.
Yeah, but you see the hat would go so well with the shirt, man.
Are you sure you want to spend another $500 on hats?
Hey, if we have people sign up because of your outstanding marketing skills,
Dude, we're about to increase the subscription rate to RLR just because of the need for hats.
All right, well, what do you have next?
Yes, I think great thoughts. So I will give you the physical examination. At the time of presentation, her blood pressure was 90 by 60. Heart rate was 148 per minute. Respiratory rate was 36 per minute. And saturation was 90% on room air. Temperature at the time of presentation, she was afebrile, 98.4. Regarding the general examination, she was conscious and oriented to time, place, and person. HEENT pallor was present. Pupils were normal, bilaterally equal in size and reacting, and there was no jugular venous distension with no evidence of icterus. And cardiovascular examination was unremarkable. Abdomen exam was unremarkable as well. Pulmonary examination, chest revealed bilateral creps on both sides. And neuro examination was also unremarkable. She was conscious oriented. Regarding the extremities or skin exam, there was no peripheral edema in the legs. And the muscle strength as well was intact. There was some black necrotic crust on the radix, that is upper part of the nasal bridge. That was on the physical exam. Then she was started on supplemental oxygen support. So we got an arterial blood gas on the supplemental oxygen, which revealed pH of 7.29, partial pressure of oxygen 171, and a PCO2 of 30, with a lactate of 0.7 and bicarbonate of 8.3. And we also got an ECG with that elevated heart rate. I might just share my screen for a minute and I can share that ECG. So this was the ECG for this patient. And I'll take a brief pause here.
You up for it, Professor? You want me to?
I can.
I don't know if it's me. Can you guys hear Professor, or did something happen to my? Oh, you can't hear him. Your audio suddenly disconnected, Professor.
How about now?
Yeah, perfect.
Okay. All right. So whenever you're interpreting an electrocardiogram, first of all, before you even go into the EKG, you have to ask the question, why was the EKG done? Right? Like, I mean, people come into the ED and they get all sorts of tests, but unless there's like a purpose behind the test, it's hard to really interpret the test. I think that stands true of any test that we order. So, Robbie, to answer that question, can you give me the quick summary of the case so far in your mind? Like, what is the frame of this patient?
Yeah, I think the frame of my patient is a patient who has rather acute cardiopulmonary compromise and the
Beautiful.
background of fever, probably.
I love that so much. And if you think about that, if we go back to the physical exam, because you need all of that to be able to analyze this EKG, not so much the crusting on the nose or the cartilage, which suggests necrosis, and we can let Robbie tackle that. But we have someone who has acute cardiopulmonary decline with bibasilar crackles in the lung. And so when I'm looking at this EKG, I'm like, okay, could the heart be the culprit? Or because it's an inflammatory thoracic syndrome, could there be like a vegetation on a valve that's prolonging the PR interval or affecting the conduction system and the AV node? I say this because an EKG in isolation is really not, it's often not that helpful unless there's like a pretest or a hypothesis going into the electrocardiogram. So for this patient, it's like, okay, is there anything sinister happening at the level of the heart that might be on display in the EKG? And when I'm interpreting EKG, I really ask 3 questions up front. This is like my broad overview. I don't go through the 6 steps that they teach you in medical school. I basically ask the question, is it narrow or wide? And here it's narrow, because if it's wide, then you get into a bundle branch block, etc. Is it regular or irregular? In order to determine this, it's good to have calipers, or you just take a piece of paper and you mark out 2 QRS complexes and you see if they march out. Here by the naked eye, it looks like it marches out perfectly. So I'd say this is narrow complex, it's regular. And then the third question I ask, is it fast or is it slow? And I mean, I've memorized that whole 300, 150, 75, or take the number of beats. Who cares? It's going to tell you on the EKG, this just looks fast. So based on my initial assessment, this is regular, it's narrow complex, and it's fast. And by the way, isn't this what you would expect in someone with acute cardiopulmonary decline? Like they have to compensate to try to get their blood pressure up. Okay. Then the next question I asked, which I think is a really important one, is it sinus or not? Because not every regular rhythm is sinus. And to answer that question, I look at lead 1 and lead 2, and I look for the P wave. Lead 1's P wave is hard to see. The T wave is easy. The P wave is hard. But in lead 2, I can see the P wave nicely. And I see that has a good relationship with the QRS. So P wave, QRS, P wave, QRS. And then in AVR, the P wave is inverted. Why in sinus rhythm? Why is the P wave inverted in AVR? Because that's a limb lead on the right side. Electrical activity is starting at the SA node and pushing left and inferior. That's why in the AVR, the P wave is inverted, and why in 1 and 2, the P wave is upright. So now, Rabih, I can easily say this is sinus tachycardia. Now, the other thing I do is I look to see if there's any ST segment changes, because this is going to be critical in our patient with acute cardiopulmonary decline. And in order to be able to tell if there's ST segment changes, you have to be able to identify the isoelectric line. The isoelectric line, I use the PR interval. Some people use the TP segment, which either or is fine, assuming you're in sinus rhythm. And here, I'm just going to eyeball this real quick. Nothing really jumps out as very, I mean, look, at V4, V5, there's some ST segment depressions sort of going upward. So, but that doesn't bother me, honestly, not in a sinus tachycardic rhythm. And even in V2 and V3 particularly, it's very mild. So I would say, looking at this EKG, you could look at the voltages too. And for the voltages, the easy way to remember it is that if it's less than 5 in these leads on the right, 1, 2, 3, AVR, AVL, AVF, then you have low voltage. If it's less than 10, down there in the leads in the middle, V1 through V6, these are the precordial leads. So the easy way to remember, on the right side of the EKG, 5, add another 5, you get 10. 5 plus 5 is 10. Then you get to the middle of the EKG, the precordial leads. I'll tell you, like on the right side, yes, some of them are less than 5, but others aren't. So is it slam dunk? No. I think assessing the JVP is more important than what this EKG shows. So my read, and Rabih, I love your read, is sinus tachycardia, non-specific ST segment changes.
Yeah, well, one, I think we should just all acknowledge what happened there. That was a beautiful assessment. I think a beautiful assessment, also distillation of the EKG. I have to say, when I first looked at it, Prof. Rez, I was like, this is 100% sinus tac. And then I made the observation that the heart rate is exactly 150. And so if there's an arrhythmia that's going to fool you, well, Prof. Rez, maybe I can handle my tea. You're just like crushing the EKG teaching. So when you layer in the observation that the heart rate is 150, how do you balance that? How does that fact influence your thinking?
Yeah, this was actually taught to me by Lawrence Tierney, Gurpreet's mentor. And he basically said, whenever you see a heart rate of 150, you got to consider atrial flutter. And remember, atrial flutter has 2 forms. It can be regular or irregular. And it can have various degrees of block. And usually the P waves go at the rate of 300 and in flutter. And based on the degree of block, so if you have like 2 to 1 block, you have a heart rate of 150. So whenever you see a heart rate of 150, you always have to consider atrial flutter with a regular rhythm and a 2-to-1 block. But I don't know, because those P waves look pretty good though in leads 2 and AVR. The P wave looked inverted, so I'm still sticking with sinus tach despite it being 150.
I love it, Prof. Rez. Yeah, I'm right there with you. I think I would probably give it like 85% chance sinus tach, 15%
Can I say
flutter.
one more thing? So sorry. None of this matters. You know why, Robbie?
Yeah.
Because I learned this recently. I was literally recently, Robbie. I was just rounding in the ICU, and one of the cardiology attendings said, one of the biggest misconceptions of AFib is that it is not a compensatory rhythm. So like sometimes the heart is not doing well, and right now, like that's why I said the pretext of interpreting the EKG matters. This isn't someone who is just sitting down and suddenly develop palpitations. So whatever this rhythm is, it's in response to the acute cardiopulmonary process, whether it's sinus tach or a flutter because the patient has conduction disease. So it doesn't really matter how you frame this rhythm.
I love it.
Do you agree with that?
Oh wait. Oh shoot. Oh yeah. Can you hear me?
Oh yeah, I can.
Yeah, 100%. I completely agree. I
need more reassurance that I love it and that you're amazing.
No. I love it. 100% love it. I'm just not trying to. What's that? All right. I'll incorporate the rest of the exam to say, gosh, this patient's really, really sick. We verified, I think, the cardiopulmonary collapse, and just bringing in the labs is very, very interesting, Prof. Rez. So, I'm having a difficult time analyzing the ABG, because the pH is almost normal, and the PCO2 is slightly low, yet the bicarb is extremely low at 8.3. So I think I probably there's a little discrepancy because of the degree of the bicarb being low, and the PCO2 isn't that low. I suspect I might have the pH wrong or something. Well, do you mind just double checking that for me? Do those numbers add up for you?
Yeah, the normal value of pH in our setting it's 7.35.
Yeah.
And I'm actually presenting the case as it opened up to me, because we get the labs 4 hours later, and we can get an ECG because the heart rate was very high. So we just wanted to rule out if there was any arrhythmia or SVT kind of picture. But Prof. Rez, the analysis was really great. I really loved the analysis. I think the best part of the case today, and it was actually sinus tachycardia only. And we had about the black necrotic area. So we just saw that on examination. So upon further history, it was realized that she had some burn there. So it was totally unrelated to the case. So these are some of the things which can misrepresent. But maybe I can provide some labs and then we can analyze the further.
Yeah, I just want to tell people that there's something wrong about this ABG. And what's wrong about it is the degree of acidosis from the bicarb is extreme. And the only way the pH would be normal is if the degree of respiratory alkalosis was also extreme. And so the bicarb is 16 points lower than normal, but the PCO2 is only 10 points lower than normal. And so I worry that there might be an analytical error with that ABG. And so I'm not really sure how to interpret it, and would probably wait for the more accurate labs to get clarity on what's going on with that set of numbers.
Yes, great analysis. So I'll also give a POCUS echo, which was done at that point of time, which showed LVEF of 60% with a collapsed IVC. So the patient was started on IV intravenous fluids. Now regarding the labs, hemoglobin was 7.4 with an MCV of 90.6. RBC count was 2.54 million, and total leukocyte count was 7,300 with the neutrophils of 81%, and the labs reported seeing 2% myelocytes and metamyelocytes with that. Lymphocytes were 14%, monocytes 1.8, and eosinophils and basophils again were normal. Platelets were 36,000, and sodium was 143, potassium was 4.85, chloride was 106, calcium was 8.25, and phosphorus was 10.1, with a magnesium of 2.47. ESR was 140 with a quantitative CRP of 184. And serum uric acid was also sent, which was 14.5. Then we also got the RFTs. BUN was 221 with a creatinine of 5.25. Then urine routine at the time of presentation also revealed trace proteinuria, 6 to 8 RBCs, and 0 to 2 pus cells. So with the IV fluids, we had good urine output of 100 to 200 ml per hour. Total serum bilirubin was raised at 2.31 with a direct component of 1.34. AST was at 116 with ALT of 57. And total serum protein was 7.8 with albumin of 2.91. And alkaline phosphatase was 168. Some more labs revealed total cholesterol of 159 and A1C of 6.7%. PT-INR was 12.8 by 1.17, and procalcitonin was raised at 27.4. And finally, the viral markers were sent, HIV, Hep B, and Hep C, they were non-reactive. I'll stop here.
Yeah, I'll Professor, maybe I can just tackle the kidney elements of this and then leave the CBC and the other things for you to incorporate. And I think the renal element is very concerning because this patient likely has kidney injury. And the question is it acute or chronic? And I think that in the absence of known medical history and the height of the BUN suggests there's an acute component. It's very, very unusual to be able to mount a BUN this high from long-standing kidney disease, partly because of the nutritional consequences that happen. We, of course, don't know that for sure, but I think that would be my operating hypothesis. The other support for acute kidney disease is the vast majority of patients with chronic kidney disease are hypertensive unless they have an acute illness that's independent of their kidney disease. And I think soft blood pressure is a very good way of analyzing AKI because it really reduces the probability of isolated intrinsic renal disease with one exception, and that's acute tubular necrosis. So for me, I'd be really, really curious how much of this creatinine and this kidney injury washes away once we fix this patient's significant hemodynamic compromise. And if we're left with intrinsic renal disease, the operating hypothesis will often be acute tubular necrosis, but close scrutiny of the UA is going to be really, really key. Reassuringly, this patient has lower risk of postrenal disease than a man of this age because of the prevalence of BPH. I'll just layer in the uric acid here. So the uric acid can be because of overproduction, but is often the result of acute kidney injury and impaired clearance. So I think the simplest way to analyze AKI in the context of hypotension is to realize the base rate suggests prerenal disease and ATN. But I think there are some other laboratory features here to pass on to Prof. Rez that make this case interesting and have it a little bit of a twist. So, Mike to you, Prof. Rez.
Dude, it's just such an amazing analysis on your part on being so authentic to the process. And yeah, from your comment on the bicarb to interpretation of the kidney injury in the context of hypotension. And here, I don't know if you agree with this, Robbie, but I still feel like, you can take this case anywhere. And I'll just tell you my reflex thoughts, but I would want more data before creating a DDX or even speculating, because it's kind of a little bit hard to make connections. So to give you an example, when I saw the hemoglobin and the platelet count, I said, okay, this is a bicytopenia. And then I remember Amo told us that this patient had recently got IV iron. And so I'm assuming there was a component of iron deficiency anemia, though we don't know what was the cause of the iron deficiency anemia. And usually when you have iron deficiency, your MCV goes down because iron is the only external element that the bone marrow needs to synthesize hemoglobin. And if it doesn't have iron, it just can't synthesize, and you have these really tiny, reticulocytes, MCVs. But here we have the MCV of 90. And so when I see this bicytopenia, I think we always have to pause and ask the question, are we dealing with microangiopathic hemolytic anemia? And then you look at the AST, ALT, and bilirubin, and you know that when you have extrahepatic AST production, it's going to be greater than the ALT. And we know the bilirubin is slightly elevated. And so assuming that's indirect, you're getting more support for that possibility of someone with iron deficiency now having a hemolytic, because the MCV is 90 and you have these other parameters. The most common cause of MAHA in the context of a patient like this with fevers would be DIC. So this would prompt me to send a D-dimer and a fibrinogen. I'm going to park that hypothesis, and I'm starting empiric antibiotics, broad spectrum. I would be targeting the lungs, but to be frank, the lungs might just be a sequela of fluid overload from a heart that's going too fast. And by the way, iron deficiency in someone who's postmenopausal should be concerning in itself. Then I looked at the procalcitonin, and like the procalcitonin, it's not for pneumonia, it's a good test as long as you get at least 2 measurements separated by a few days or a day at least, and may prioritize bacterial. But we also saw that in COVID and viral stuff, you can have elevated procalcitonin. So to me, the patient's inflamed. I'm worried about infection. I'm worried about DIC. I don't know where all this is coming from. I'm starting broad spectrum antibiotics. But then the other way you can look at this is to be like, all right, I have ASC, ALT, and direct bili. Is that a clue to where the site of infection might be, like in the hepatobiliary system? And I think the alk-phos is also up. So I think that's also worth entertaining that hypothesis. And so when I'm giving my empiric antibiotics, I'm not only covering, MRSA, Pseudomonas, like staph gram-negatives, but I'm also covering anaerobes. And so I think for a patient like this, vancomycin or vancomycin and flagyl might be good. But dude, Rod, I really would love to know from you, like this patient's in your ED, management-wise, like really, what are you doing for them, both diagnostically and treatment-wise? Like by the time you take care of them, then I get to pretend like this is what I would do, but you're actually doing it.
Yeah, Professor, I'm right there with you. I think a lot of critically ill people, their anemia is often noise to me. So I'm really fixated on the thrombocytopenia because I find that very unique. And I think the most common overlap of hypotension and thrombocytopenia is that of sepsis. And so right there, I'm right there with you in that I'm giving this patient every antibiotic I can think of, quite honestly, and I'm not being elegant about it. And I think other management steps are really dependent on everything that you said, what the peripheral smear shows, what the repeat UA shows. But yeah, if this person's in the ED, they're getting like 5 liters of fluids because they have sinus tachycardia, as you said, and hypotension with a collapsed IVC, and they're getting vancomycin, caspo-doxy. What else do you want to give them?
Do me a favor. Look at Austin right now.
What does
he remind you of?
Hold on 1 second. I gotta search for Austin.
I'm
on my.
Oh, I'm so sorry. I should just send you a screenshot. Like
let me enjoy it.
Yeah, minus the hair. Who does he look like?
What is he?
Exactly replica.
Oh my God! Hi, Dr. Dhaliwal. I didn't know you joined me.
Austin, you look like Dr. Dhaliwal. Oh my God!
He really does.
With that angle like that.
Can you text him for me and say that?
only if you were as smart as him.
I definitely not. So, but Dr. Dhaliwal is the most humble person I've ever met. So I'm sure that he would say that I am.
Austin, the other thing is he actually kind of plays with his beard just like you are right now. So the familiarity is, the similarity is uncanny. Look at this, Prof. Rez. I don't know what you're doing to me because I'm very stressed about this patient. But Prof. Rez is so comfortable and relaxed. He's sitting there watching Austin. I think you need to make this case even more stressful for Prof. Rez. I've reached my limit, but let's see what you have next.
Great discussion so far. And the first, definitely on admission, the patient was not having fever, but she was having fever during the course of the admission, and she was having fever for 4 days before that too, as per the outside records and as per the patient. So some acute febrile serologies were sent because the patient was having fever with thrombocytopenia. So we'll consider tropical fever. So dengue IgM, NS1 was sent, they were negative. Leptospira IgM was negative. Then malaria test was also done, it was negative. Scrub typhus was non-reactive. Vidal test was performed, which had normal titers. Urine culture came out to be negative. Blood culture showed staph epidermidis in the provisional report, and then it showed no growth after that. Beta-D-glucan assay was also sent, which was negative. Galactomannan assay was indeterminate. And then something about the iron profile. UIBC was normal. TIBC was 248, that is 2 points less than normal. Serum iron was normal at 64, and percent transferrin saturation was 26%. Other than that, we got a folate level that was 19.54, and vitamin B12 was very high, more than 1537, and I think that's the maximum that can be detected in our lab. Then we also got a UPCR, which was 0.6, normal being 0 to 0.2. Then we also have PBF, which showed mild N-isocytosis with presence of microcytes and normocytes, predominantly normocytic normochromic blood picture, with no evidence of hemolysis or cystocytes in there. WBCs were normal in number and morphology. Platelets were reduced in number and normal in morphology, and there was no hemoparasite that was noted there. Then we also sent a ferritin level that was elevated at 5,252. Triglycerides were also sent, they were 361. Then we also confirmed the POCUS findings with a 2D echo, which showed normal LV size with normal systolic and diastolic dysfunction with an EF of 60%, and mild tricuspid regurgitation with PASP of 40 mmHg. Then we also got a chest X-ray, AP view that showed left upper and middle zone opacification. And there was a CT report from outside, HRCT, which showed large area of consolidation with central cavitation in the left upper lobe and lingular lobe, and patchy airspace opacities in the left lower lobe. I'll take a pause here.
Rabih, I'd love for you, because I mean, honestly, no one knows an ID in my book as good as you. If you can just share your thoughts.
You see what he just did there? Absolutely coming to the conclusion this is infection, and I'm right there with you. And I think, Professor, we finally have an angle to approach this case in terms of where that infection might be. And I think if you just go to that reflex approach of when somebody has mixed hypoxemia and hypotension, is it a pulmonary infection with sepsis physiology, or is it cardiovascular disease with pulmonary edema and shock? And I think here, with the echo findings and with the CT chest findings, the former hypothesis of a pulmonary infection with sepsis physiology is gaining a lot of ground. And I think there's an interesting thing, Anmol, for us to study, which is you mentioned the patient has multifocal consolidations and necrosis or cavitary lesions. And I would just point out to all of you that the vast majority of patients with cavitary lesions have a subacute disease course, meaning that it takes time to necrose lung. The conditions and diagnoses we know of, like tuberculosis, fungal infections, usually present with a cavitary lesion in the context of weeks of illness. And so if we take it at face value that this patient's only been sick for a few days, which of course we have yet to confirm definitively, because I'm not going to let Anmol fool me on the time course like she did last Thursday. So we don't know that. But I think when you're trying to say a patient has cavitary lesions that develop acutely, you're in a very, very narrow differential diagnosis. And that is really rapidly progressive pyogenic bacterial infections like staph, strep, and Klebsiella that can do it. And so for me, I think, Prof. Rez, my mind is inclined to label this as a patient with multifocal pneumonia with concerning features of a very aggressive organism like Staph aureus pneumonia or Klebsiella pneumonia. And I think that in the absence of overt evidence of hemolysis, the anemia is likely a consequence of the kidney injury and the inflammation, and the thrombocytopenia is the same. However, if you're analyzing this case as a clinical reasoning nerd and you see multifocal pneumonia with cavitary lesions along with thrombocytopenia, liver injury, and kidney injury, this would suggest a couple of very interesting and cool possibilities. The first is Legionella, which would be a worldwide exposure. And then whenever you're in India and you have an acute severe multifocal pneumonia, along with a patient having any cutaneous finding whatsoever, you have to think of the two M's, melioidosis and mucormycosis. Melioidosis requires no risk factors, those often present in patients with diabetes. Mucormycosis does require immunocompromising condition, but that immunocompromising condition can be just as simply as having COVID. So what am I thinking here, Prof. Rez? I think that the frame has become a little bit clearer. This is a acute severe multifocal pneumonia. And in all comers, this would be staph, strep, and Klebsiella. I think the epidemiology of this patient being in India, it reinforces the two M's, melioidosis and mucormycosis. And then the worldwide association of multifocal pneumonia with thrombocytopenia, kidney injury, and liver injury makes Legionella a possibility. And so I think you just have to fine tune your antibiotics here, which you put on vancomycin for the Staph aureus hypothesis. You definitely have to put on anti-pseudomonal coverage now because melioidosis has a similar resistance profile to Pseudomonas. In fact, it's called Burkholderia pseudomallii. And then I think for optimal treatment of Legionella, you have three options to treat Legionella. You have a fluoroquinolone, azithromycin, and doxycycline. The data is equivocal, but I know ID doctors that I've worked with believe that the fluoroquinolones are probably the most effective for a patient this sick. So I would be giving this person vancomycin, Zosyn or cefepime or meropenem, and quinolone. I'm really, really worried about her. I think the prognosis in this situation is not great at all. But in Unmol's very capable hands, miracles do happen. Prof. Rez, what else do you want to sprinkle on or add to this ramble?
It would be an injustice to add an additional word to what you did. That was just, dude, I felt like I was at the Mass General CPC session right there.
Hey, that's what Unmol brings to it. All right, Unmol, mic to you, my friend.
Okay, that was a great discussion. And so we move over to the next aliquot. We also got an ultrasound whole abdomen, which showed cholelithiasis with the calculus measuring 14.4 in the lumen of gallbladder, just in view of all the liver derangements we saw in the labs. We had normal liver, spleen, and kidneys. A fibrinogen level was also sent, which was 480. And a spiral CT chest was also done in our hospital that showed a patch of consolidation with surrounding ground glass haze in apicoposterior and inferior lingular segment, and no cavitation was seen in our hospital. Subpleural reticulations were seen in both lower lobes with fluid thickening, and nodular opacity giving reverse halo appearance in the medial basal segment of left lower lobe and apicoposterior segment of left upper lobe. Tracheal airway was normal and minimal left pleural effusion was seen. Multiple subcentimetric lymph nodes were seen in the prevascular location, and the basic impression of the CT was lobar consolidation in the left upper lobe. And as you said about the antibiotics, initially when nothing we knew about, then I think the patient was started on broad spectrum antibiotics like ceftriaxone and doxycycline. The patient was managed with inotropes and IV fluids. But once the lab started coming in with the procalcitonin and everything, I think the patient was started on meropenem and teicoplanin. Teicoplanin, I think, is not used in the US. It is similar to vancomycin. It's a glycopeptide antibiotic. And ultimately, with all of that, the sepsis started to resolve. The PCT dropped down significantly, and blood pressure was stabilized. The patient was off inotropes, and heart rate was closer to normal level. Regarding the course of blood urea nitrogen creatinine, so BUN started from 221 and it went down 234, 170, 137, and 79. So it was normal by the 6th day. It was around 60 or 46 around the 6th day. And then the course of creatinine was 5.25 to 5.03 to 2.65, 1.68, and 0.9 in the 5th day of the admission with the IV fluids and the IV antibiotics. So everything was coming down. But there was the trend of CBC was very interesting. There was prominent persistent in anemia and thrombocytopenia. HP was around 7.4 or 6.7, 6.2, 5.2, 6.9. And in fact, the patient received 2 packed cells during the admission, but still the anemia persisted. And the platelets, they varied between 16,000 to 36,000. I think these were the values in which the platelets were varying. So the platelets were not improving, the hemoglobin was not improving, and there were some intermittent still fever spikes around 100 degree that were present. Now, my question to you is, we discussed something about the elevated ferritin or the elevated triglycerides. How do you see those lab values, and how do you analyze the case now, and what would you do next?
This is starting to remind me of the walk through UCSF Harry Hollander rounds, where he's like, hey, Reza, do you have anything to say? Well, I will say something here. Almost question, so the patient is on an antifungal, yes, in addition to broad-spectrum antibiotics?
I think the patient was not given antifungals. I know the patient's course because I admitted the patient, so the initial management was, I did that, but then ultimately I could not follow up with the patient. I went when the final diagnosis was made, and I was allotted that day.
That's super helpful. I think that, you know, first of all, we have to start with like the disconnect between clinical improvement, but laboratory persistence of badness, to just say it plainly. Meaning that the patient's getting better, the kidney function's improving, the fever has subsided, the blood pressure has normalized. I just want to make sure I'm capturing all that's right, Robbie? That's okay. The patient's getting all better, and then you have these continued laboratory abnormalities. So what does that mean? Well, let's first focus on the parts that are getting better. And people get better because time passes or you do an intervention. In someone like this who is so sick and who is so decompensated, it was our intervention. Like it had to be. Like I don't see someone going from this acute cardiopulmonary distress, hypotension, fevers, all this stuff, to just getting better. So I'm inclined to think one of those antibiotics targeted an organism. But what do we do with the hemoglobin and the platelet count? I think, you know, the fact that the smear didn't show MAHA, like you need a schistocyte, there was no schistocyte. Furthermore, there's no evidence of acute DIC because the fibrinogen is elevated. Of course, you would send an LDH and a haptoglobin, but you're really making an argument against this being a peripheral destruction. And we're giving blood products and they're not getting better. So I do want to say this. I would definitely send a haptoglobin. I would definitely send an LDH to round up and make sure there isn't any peripheral destruction. Because that should be the first thing that you think about, is that if you're giving someone blood product and they're not getting better, and even if you have bicytopenia, you should start in the periphery before going more central. So maybe almost before I continue to analyze, was a haptoglobin sent or an LDH sent?
That was something I was concerned that when I reflected back on the case, that I believed LDH was not sent, and that is something I believe should have been sent, but it was not sent.
Beautiful. So, you know, because I think, Robbie, I'm still there. Like, I mean, if you frame now, let's just focus on the anemia and thrombocytopenia. As someone who is persistently anemic and thrombocytopenic, despite giving blood transfusions, it really prioritizes some kind of hemolysis, and then you start thinking, could there be an autoimmune hemolytic anemia and an immune-mediated thrombocytopenia? I would never rush to give this person immunosuppressive. I think almost what you were pointing out with the ferritin and the triglycerides is, could this be HLH, hemophagocytic lymphohistiocytosis? And that often in adults is secondary to a primary insult. Usually it's going to be lupus, like an autoimmune disease like lupus, a cancer like lymphoma, or an infection like infectious mononucleosis. So I think that, sorry. Is it still happening, Robbie? All right, let me get off the mic. Take over the mic, man.
My friends, it sounds like little farts. It's really funny.
I had a lot of beans this morning. Wait, let me switch the mic and see if it works. 1 second.
Oh, it worked. It's fine. It's gone.
now I switched the mic. Is it okay?
Now you sound so beautiful. Oh my gosh.
Well, thank you. Thank you.
Oh, look at that.
Never
Look at
texted
that.
me in the middle of a conversation, yet he texted me. That had to be something important. But yeah, so Almo, that's where I'm at. And I'm going to be interested in what Rabih has to say. But I think that the fact that they're getting better with antibiotics clinically really lessens the likelihood of an underlying lymphoma or underlying lupus or something like that, autoimmune process. To me, making like secondary HLH less likely, and I'd be more focused on what's happening in the periphery. But would love to hear from. But hey, Andrew, YouTube deserves to hear this nonsense from me. Rabih, take the mic, man.
Oh, yeah. Maybe we can hand the mic to Anmol just for the sake of time because I have to go around in a couple of minutes. So, mic to you. Nothing to add, Prof. Rez, as per usual.
Yeah, great discussion there, and I think the providers, they were also concerned about a possibility of HLH there, that why the patient was having bicytopenias with hyperferritinemia and hypertriglyceridemia. Still, the cell lines were not improving, so they decided to proceed with the bone marrow biopsy, and they got a blood film there, and which, again, I'll just repeat that, which showed predominantly normocytic normochromic RBC picture and TLC within normal limits with relative neutrophilia, ANC count of 8,400. Then platelets markedly reduced in number, normal in morphology. DLC was just the same as I said, with the neutrophils of 81%. Blood counts at that time was HP of 6.7, TLC of 10,000, platelets of 22,000, with the corrected reticulocyte count of 0.3%. And then bone marrow aspiration was done, which showed hypercellular marrow with prominence of lymphoid cells constituting 70% of all nucleated cells. Erythroid precursors were depressed and showed normoblastic maturation. Myeloid precursors, they showed orderly cell maturation, and megakaryocytes were seen. Few plasma cells were noted. So basically, the result was a hypercellular marrow, cellularity of 70 to 80% with diffuse prominence of lymphoid cells. The cells had high NC ratio, fine chromatin, prominent nucleoli and scant cytoplasm. All other hematopoietic elements were depressed. And just a final thought, what do you think it could be?
It's a really interesting bone marrow result. I think, Anmol, we're hearing that the bone marrow is full of what sounds like, and sorry, I had to do something a little urgent, so was listening along. It sounds like very abnormal appearing cells. And I think the question is the abnormal appearance of those cells a marker of something wrong with them, or a marker of their reactivity to something distant and sinister? And I think it depends so much on your astuteness of your pathologist, because you can definitely have activated angry cells responding to an infection that look to people like they're inherently mutated. So I think the next phase would be to do cytogenetic analysis of these cells. And the two possibilities are that these are very reactive to a systemic sinister process, but more likely, based on the amount of them and the degree of visual abnormalities the pathologist is noting, represents a primary bone marrow process, in which case the systemic fingerprint in the lungs may be as a result of the immunodeficiency that comes with this disease process rather than the origin of it. So there's two really simple possibilities here. Either there's an infection that triggered a reaction in the bone marrow, or there's a bone marrow problem that causes immunosuppression and subsequent consequences on the lungs. So I think cytogenetic analysis would be really key here, but the number and degree of abnormalities really raises concern that all along the patient's systemic features of generalized weakness, bone pain, refractory anemia, and thrombocytopenia are the crux of the disease, and the pulmonary manifestations are a consequence of that immunodeficiency. Anything to add, Prof. Red? All right, Mike, to you, Anmol.
Yeah, so very great discussion. So I'll just add the flow cytometry report. This was actually a very vast case, starting with fevers, and then they actually were considering HLH. Nobody was actually thinking about a primary bone marrow disorder there. But the bone marrow biopsy flow cytometry showed positive kappa and positive CD20. All the other markers were negative. So that immunophenotypic findings were consistent with B lymphoproliferative disorder. That was non-Hodgkin B-cell lymphoma and likely marginal zone lymphoma. And so this was basically the final diagnosis of the patient. And there was definitely a superadded bacterial infection with that procalcitonin and all of the things, or likely a fungal infection also, that is a possibility. But underlying immunocompromise in this patient was non-Hodgkin B-cell lymphoma. And then this diagnosis was conveyed to the patients and their relatives so that the patient can be shifted to hemato-oncology. But they did not expect this diagnosis at all, and they refused all sorts of treatment, and they left without taking any treatment.
Rabih, you should get to rounds. I'll be here to anchor the closure of this. Almo, that was a phenomenal case. I think, man, I don't even know where to start. Like from the beginning, like this teaches you so much about medicine and thinking through a case. And there's a lot of nuances too. And also a lot of information that you have to tease out signal versus noise. And so I thought the entire journey was just unbelievable, from like just interpreting the EKG and realizing that's not the main culprit, but then pivoting to being like, there's an infection and the patient's getting better, but there's a persistent lab abnormality. So then the question becomes, is it the infection driving that, or is it something primarily in the marrow? And I think the fact that they got better and that stuff persisted lessens the likelihood that it's a secondary marrow process, right? Because why wouldn't it get better if the infection that's driving it calms down? So then that prioritizes the inverse that Rabih so eloquently, the picture he painted for us, that everything is happening in the marrow. They became deficient, they got their infection, you treated that, but you didn't treat the underlying process. I mean, this is such a good case. Like, wow. If you don't mind, just share with us like why you brought this case, and then we can pass the mic to Lara to finish out the session.
Yes, I actually have something to share. I think on Friday VMR, that is to both Dr. Rabih and Dr. Reza, I've presented multiple cases, but to both of them I presented only 3 cases. And coincidentally, all the 3 cases started with fever. But none of them actually required antibiotics. So the first case I presented was TB pericarditis, unresponsive to antibiotics. Second case was fever, acute leukemia, not responsive to antibiotics. This patient's one component was definitely responsive to antibiotics and required that, but the other component did not. So I think the main conclusion is fever is not equivalent to antibiotics. That is sometimes seen in many facilities that the patient is having fever, so okay, the antibiotics will treat it. But fever can represent multiple things. It can be infection, autoimmune, inflammatory, malignancy, anything. So we should be very careful about doing that. And a very sad diagnosis for the patient because it was an old lady. And sometimes you get that lady had a long course in the hospital, and the diagnosis actually was very surprising for everybody. Nobody expected that. But yeah, I just wanted to share the case for that purpose so that we can actually go back and reflect to see and understand what we can learn from the case. And yeah, thank you very much.
Almo, I think those are such great points you make. Thank you for bringing this case. Lyra, mic is yours, my friend. You're the only thing keeping us from all leaving, so please take your time.
Yeah, thanks all so much for this amazing session, and I'm gonna be brief because we're already in overtime. Yeah, we started off with talking about fever, which basically we can translate to systemic inflammation going on in this patient. And when we see when we think about inflammation, we need to ask 2 questions like, what is it? And here we can use our infamous IMate mnemonic when we start thinking about an inflammation with infection, and then go to other etiologies like malignancy and autoimmune diseases. but always start with an infection. And the second question is, where is this inflammation? And here we had a source in the legs, but also we broadened our differential because of the systemic cardiopulmonary disease. Yeah, and also when we talk about infection, we made a really important point that we can use procalcitonin to guide us, but it's not 100% specific for bacterial infection. So we can use this as a clue, but not as definitive tests. And when we think about infection, we need to understand the response that this patient is having. Is he getting better with appropriate treatment or not? And clinically, the patient got better, but some abnormalities in his CBC persisted. So we now started thinking about abnormal bone marrow findings. And here we can have two possibilities. If either this is a primary bone marrow disease, or this is exaggerated bone marrow reaction to some secondary process. And in this case, we were thinking about infection. And here, to answer this question, we need to, again, understand the response of the patient to the treatment. And if we overlap the abnormal bone marrow findings with the infection, we can also think of two possibilities. Either this is a primary disease leading to immunosuppression and subsequently infection, or this is a primary infection leading to abnormal marrow disease. And here's the CBC abnormalities were persisted. We were inclined to think towards the first option here, which was the final diagnosis in this patient. And thanks everyone for this amazing session.
Lyra, that was phenomenal. Way to make it concise despite a complex case. I want you to have the last words. What do you want to say to the YouTube people watching this?
I'm not sure I'm going to say right, but